Hi, this is Lisa Clark. I'm going to go over post-op pediatric delirium agitation and how we can better safely discharge and treat these patients. So we have several objectives. We're going to try to differentiate pediatric emergency delirium with agitation and pain in the postoperative setting, which can be quite a struggle. Identifying those risk factors associated with delirium and agitation. We're going to describe the assessment tools we have in order to differentiate those three things. And then we're going to look at treatments, pharmacological and non-pharmacological, and what we should do in the perioperative setting. So we have a lot of challenges with this. Risk factors and prevention, if we can prevent it, it's great. We'll go through some of the triggering things. Our ability to separate emergence, agitation, delirium, pain, and the baseline patient's behavior is kind of difficult sometimes. Use of standardized delirium tools and pain assessment tools, that's been a challenge, but we're working on that. Selection of proper treatment, so knowing what to give, how quickly, not being afraid of giving treatment if your kid is very, very agitated. Standardized documentation of mental and neurological assessment. So I think we could probably improve on that greatly. So what is pediatric emergence delirium? So this is a psychomotor disorder that occurs usually early in the postoperative and post-anesthesia stage 2. And so basically it's a motor agitation state, complication from anesthesia. What you're going to see is non-purposeful movement. You're going to see changes in the child's awareness and attention to his environment, and disoriented. They may be in their mother's arms and keep screaming, "Mama, mama, mama," not really realizing where he is. They can be hypersensitive or they could be hyposensitive. Typically, we see hyper where we are to stimulation. You're going to see moaning, restlessness, involuntary physical activity, disorientation, and thrashing. The onset of delirium is usually within about 30 minutes after the offset of anesthesia and may take about 15 to 30 minutes to subside. However, it can last for up to 2 days. So the other thing we see are anger and maladaptive behaviors. Movements appear purposeful. So these children, they make eye contact, they bite, they kick, they can verbally exchange with you what they want, what they don't want, especially. So that's one of the things that makes us think delirium versus this. Pediatric surgery patients have a lot of challenges, especially our children here. They can be exposed to in vitro medications, drugs. They can have, foster care. They could have abuse in the past, not a lot of support at home. Often children are very angry at being brought in, and it's just a strange environment. So safety is our number one priority. We cannot safely discharge these patients when they're so disoriented. We can't put them to phase 2. We really, really, really need to jump on it quickly to be sure that these kids are safe. A child yelling, kicking, screaming does not meet the minimal agitation criteria and has to be evaluated by anesthesia prior to treatment. The anesthesiologist is ultimately responsible for that phase 1 PACU discharge to phase 2. So emergence delirium and maladaptive behaviors, there's some significant details about their risk development of maladaptive behaviors after delirium. It's about 20%, but it can be up to 80%. So these children go home and they can have serious behavioral issues. You can have sleep and eating disorders, separation anxiety, aggression, and these behaviors can last hours, even to a few weeks. So risk factors, what kind of are the risk factors for these behaviors? So high preoperative anxiety of the child and parent caregiver, that's like in a ton of research. If you can get the parents and caregivers' stress level down, the child pulls from that, and so if you can get them down, they're going to be good, a little bit better. Patient age, younger, 3 to 7 years old, are 18% more likely to develop emergent delirium. Any pre-existing behavioral conditions, so temperament, cognitive skills, sociability, coping mechanisms, if they lack those, their risk factor is much higher. Children with delirium are 1.43 times more likely to have maladaptive behavior changes. And the type of surgery that's pretty common is ENT, ophthalmology, and dental. The other trigger that's shown in research is sevoflurane, the anesthesia gas, which unfortunately we use for almost everybody. All right, so we've been looking at pediatric emergence delirium, and we were doing a study tool. So we want to document agitation, anxiety, or behavioral issues prior to surgery. That's going to be huge because we need to know the baseline. We want to, in the future, we're going to use this tool called the CAPD. It's the Corneal Assessment of Pediatric Delirium. And Cerner's building it for us now. It's similar to the tool that we have that we've used before. And so greater than 9 indicates emergence delirium. We'll go through that tool. I'm not sure when go live is yet. We also use FACES. FACE is the FLAC scale for pain assessment. So greater than 4 on that indicates pain. For those children who come out of surgery and they can't verbalize anything, these two tools are extremely helpful in differentiating delirium from agitation. FLAC is live now, and it's actually got a number system to it, so you can actually use it under the pain assessment. Standard documentation area for delirium, agitation, and orientation in the EHR. So we'll talk about where to document, and then our treatment options we're going to talk about. So this is what the CAPD looks like. Now at the very top of it you see a RAS score. Please ignore that. This tool is going to be used all across Western North Carolina HCA sites, and that includes ICUs. The RAS score is for PEDS ICU. Okay, so it's not something we have to do. But the rest of it is very self-explanatory. So when the child starts arousing, do they make eye contact? Are their actions purposeful? Are they aware of their surroundings? Do they communicate anything to you, needs or wants? And then the other part is the child restless? Are they inconsolable? Are they underactive? Or does it take a long time for them to respond? Okay, and so you would just do this on arrival. The FLAC scale, I'm not going to go through great detail on this because it's actually live right now, and it's pretty self-explanatory. Okay, greater than 4 means they're probably in pain. There's no reason why they can't be both, delirious and in pain, and we'll talk about that. So emergence delirium and pain intervention. So there's a lot of things we can do pre-op, intra-op, and post-op to help alleviate some of this. So pre-op, we used midazolam. We can use Precedex in children. Electronics, medical play, and of course decreasing that parental anxiety and the children's anxiety helps a lot. Intraoperatively, they'll use Precedex. They'll use a Precedex at the start of the case and the end of the case to get them through that phase 2 anesthesia. They'll use propofol, and then they'll do pain management while they're asleep. Postoperatively, when they get to recovery room, caregiver parental support. Try to get the caregiver back. It's always good to have another set of hands when you have a child that's kind of thrashing about, and try to keep them safe. Precedex, pain management, and trying to limit that stimulation to the child. Keeping one nurse, dim the lights, decreasing the noise, try not to hold them down, kind of thing. Differential diagnosis, we don't see too many of these because our kids are fairly healthy going in, but you can look at maybe hypoxia, other things. So barriers to early resolution. So assumptions that the disturbance is a behavioral issue. Oh, this kid's just a crazy kid. No, don't assume, because if they're not clicking, it could be delirium. Inappropriate use of restraint. So you do not want to restrain a child. You have to keep them safe, but if you cannot restrain their arms, okay, unless they're hitting themselves, it's always a little less disturbing for the child. Delay in treating pain or agitation. So if your child has been screaming for 20 to 30 minutes, it's probably, it's a time to go get something. Leaving them to scream for 20, 30 minutes is a little excessive. There's nothing wrong with giving them a little Precedex to try to help them cope. Too many caregiver staff with too many voices over the patient. So we just get too much stimulation in PACU some days. It's just better to get a caregiver there, get them in a dark, quiet spot, and just let them chill. Delay in reuniting the child with a parent or caregiver. So you're sitting there wrestling with them, and nobody's going to get the parent. That it's not going to help you reorient your child too much. Overstimulation, forcing fluids. There's no reason why a child has to drink in phase 1. If they're just trying to cope, don't try forcing fluids. It'd be great in phase 2, try to get them to drink something, okay, but that's not a game changer for them not to drink. Nurse discomfort, the use of medications under treatment of pain. So we need to try to get more comfortable giving Precedex right off. Best thing about Precedex is that it has pain management properties too. So if you're not sure your child's in pain, if you think they're just delirious or you think they're just at, pain versus delirium, give Precedex. You're gonna help both. So it's a twofer. Precedex is now in the Pyxis and PACU, so it's much easier to access. So delirium agitation, documentation. So it's going to be really important that you document that mental status. Agitation, resistance, crying, restlessness. If they're restless and they're going, I want this off, it's probably not delirious, it's probably just they want stuff off. And I usually document, I right click and I document, he's fighting to get their IV out. I mean, that's pretty common. When that child settles down, it's really important to put in there appropriate. If they've become reoriented and they've settled down, it's important to put appropriate in there as your assessment again, because that lets us know the time frame of how long they were agitated, okay? And we're trying to change our mode of medications and what we're giving and things like that. We want to kind of see an outcome. So mental assessment and documentation, anxious, if they're wanting their parents, irritable, doesn't want to be touched or stimulated, make a little note. You can right click and make a note. Put more details in, okay? Other things, impulsive, there's a place for confused. There's also self-endangering. So if that kid is just really thrashing and they're big, you need to call anesthesia and get interventions right off the bat, okay? We need to keep them safe. Neurologically, there's confusion, disorientation, okay? There's that too. You look at the level of consciousness, and if they're not following commands, no, not purposeful, that's a really important thing to write. Not that they're just sedated, but they're not, or if they're just, thrashing, that they're not purposeful. So this is a good place to put that. There's the FLAC scale again. Pain management, other things, all the things that we do, we don't always document on, okay? Putting a warm blanket, emotional support, dimming the lights, massage. I've given massages to kids, tried to settle down. Therapeutic touch, provider, of course, making sure that the patient's family is there or caregiver. That's really, really important. When they do come back, you can put participating in care at bedside, and you need to verify the armband, okay? Now, the developmentally appropriate care is at the bottom of, a lot of people don't know this is here, but it's at the bottom of patient activity. So you can put in things like age-appropriate toys. You can right-click and put the Vecta, okay? If we use the Vecta for somebody, patting the side rails, we do that a lot. We don't document it. So this is actually in there, okay? Decrease in stimulation, decrease in noise. We do all those things, but we don't always document it, okay? Discharge policy, we talked about. It's really, really important that there's minimal agitation observed, okay? Minimal agitation, controlled pain, emotional support, and safety. So if the CAPD is still high, greater than 9, the anesthesia needs to evaluate them before they go to phase 2, okay? I'm going to assign this PowerPoint to people so they can see the PowerPoint, but then we can send this YouTube to everybody.